Hello, everyone, and welcome to today's webinar, Enhancing Risk Stratification in Early Colon Cancer with TNM-I Immune Staging. Focus on Stage 2 T4N0 patients. I'm Christy Jewell of Labroots, and I'll be your moderator for today's event. Today's educational web seminar is presented by Labroots and brought to you by HalioDx. To learn more about our sponsor, please visit HalioDx.com. Now let's get started. I do remind everyone that today's event is interactive, and we encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We will answer as many of your questions as we have time for at the end of the presentation. Also, please notice you can share today's webinar on your personal social media. Just click on the social sharing tab to let your friends and colleagues know about today's live event. Now, if you have any trouble seeing or hearing the presentation, click on the support tab found at the top right of the presentation window, or you can use that Ask a Question box to let us know you're experiencing a problem. Today's presentation is educational and thus offers continuing education credits. Just click on that Continuing Education Credits tab located at the top right of your presentation window and follow the process to obtain your credits. I would now like to introduce today's presenters, Dr. Graham Poage and Dr. Jérôme Galon. Dr. Poage is the Medical Science Director for HalioDx, and Dr. Galon is the Director INSERM Cordelier Research Center in Paris, France. For complete biographies on our speakers, please visit the Biography tab at the top of your screen. Dr. Poage, Dr. Galon, you may now begin your presentations.
Thank you very much, and thank you all for joining us this morning, this afternoon, this evening, wherever you are across the world. Thank you very much. We are excited to have you with us to talk a little bit about a technology that's useful in colon cancer and many cancers to come here. So I am Graham Poage, obviously with HalioDx, the immuno-oncology diagnostic company. We provide oncologists and biopharmaceutical companies across the world with first-in-class immune-based diagnostic tests, IVD development, as well as clinical-grade biomarkers that are available across the world. So I will move on to the clinical portion of this presentation, and we'll talk about what are some of the challenges in treating colon cancer patients. As many of you know, the TNM classification system is really the gold standard for risk assessment of early stage colon cancers. If you look on the left, the TNM helps to understand what is the risk of recurrence for colon cancer patients. But it's a bit of an imperfect system because if you look across the continuum of clinical risk in terms of staging, it's not exactly linear, such that some stage 3 patients have a better survival profile than some stage 2 patients and vice versa. Now, all of these patients are treated with or undergo surgery, and then the choices depend on the clinical stage in terms of chemotherapy decision-making types of decisions. And because the risk-based estimates are often not personalized for the individual patient, they're based off the population data, many of these patients end up being overtreated, particularly when it comes to the adjuvant chemotherapy decision, and some end up being undertreated, where the risk is thought to be low, but it actually is much higher. So looking specifically at stage 2 patients, amongst all of the complex clinical pathologic scenarios that are observed, you know, what eventually comes out and is seen in these study presented or published in 2015 is that really the choice to treat or not stage 2 patients with adjuvant chemotherapy is highly heterogeneous depending on which country, which region, which hospital the patient seeks care. Ranging from for all, and this is across all stage 2 patients, 7.1% of patients in the Netherlands get treated, whereas almost 30% of patients that are stage 2 in the U.S. get treated. And there's clearly not some biological difference amongst tumors in the U.S. and across different places in Europe. It really comes down to the risk assessment and the perception of risk for these patients. And then moving to stage 3, we think about this as a scenario when almost all patients are treated with adjuvant chemotherapy. So if you get 100% of these patients being treated, up to half experience significant adverse events in terms of neurotoxicity, myelosuppression, and a number of other types of risk to these patients. Now we estimate that about 20% or 50% of these patients are cured with surgery alone and don't need the adjuvant chemotherapy in this setting. 20% of those patients end up being cured with chemotherapy, and then the remaining fraction, about 30%, despite being treated with surgery and adjuvant chemotherapy, these patients relapse regardless. So there's an intrinsic insensitivity to adjuvant chemotherapy for this patient. So when you think about these two paradigms, it can be challenging to determine what to do for these patients. So the Immunoscore was developed to provide a more individualized assessment for these patients. And the research dates back many years. Jérôme Galon, who is on the call here, and we're excited to have him present today, was one of the inventors and received an award in 2019, honoring his creativity and its contribution on technological process and economic growth to improve patients' lives. This was first described in the early 2000s, so many years of research have still gone on in that interim period. The clinical development and validation studies include over 6,000 patients. The 7 publications is way out of date actually by now, and the clinical assay is now available in more than 25 countries. Just this year, actually, the World Health Organization, in their Blue Book classification criteria, the essential and desirable diagnostic, mentions the immune response as being an important part of the risk assessment process. And this is really a testament to the work Jérôme and others have put forward. So the Immunoscore was developed with this idea in mind to help early stage colon cancer patients in terms of better predicting an individualized risk of recurrence for early stage colon cancer. And how is this done? The immune system actually is directly measured in an immunohistochemical-based analysis of CD3 and CD8 positive T cells, and that as it is measured spatially in terms of being in the core of the tumor as compared to being detected in the invasive margin. It's an automated digital pathology-based assessment ensuring reproducibility and accuracy, and it is clinically validated in many colon cancer patients. So when we think about, where does this fit in with all of the other factors, it is a multi-parametric complex decision whether or not to treat these patients. TNM staging, as I mentioned, is probably the majority factor in determining what to do in terms of risk assessment, although a number of other factors shown here on the bottom of this pie chart are typical other factors that are included in the decision of whether or not to treat with adjuvant chemotherapy and what is the patient's risk of recurrence. But what's important here is that when the Immunoscore is included in this complex multifactorial risk assessment process, it actually contributes a large fraction of the information and the individualized risk of recurrence for the individual patient. So let's move into some of the evidence here supporting the use of Immunoscore for clinical decision-making and risk assessment. Particularly its focus on stage 2. First, in 2018, as published in The Lancet, Franck Pages, Jérôme Galon, and others published a multi-international consensus validation of the Immunoscore. It was a massive effort led by the Society for Immunotherapy of Cancer group, and the statistical analysis was independently performed at the Mayo Clinic here in Minnesota. And this analysis included over 2,500 patients in total. In the subset of stage 2 patients, as shown in this slide, 1,434 patients were represented. And what was demonstrated was that the Immunoscore could identify patients at a lower risk of recurrence. The blue line on top being the Immunoscore high patients, where they had a high degree of immune cell infiltration into the tumor and the invasive margin, whereas Immunoscore low patients had a much higher risk of recurrence, and their tumors were associated with a lower degree of T cell infiltration. Now, the question is, okay, so if you look at stage 2 patients, which of those patients end up getting treated with adjuvant chemotherapy? The clinical pathologic risk factors that physicians utilize to understand and individualize the decision in terms of risk assessment are a number of factors, such as T4 status, again TNM, the characteristics of the tumor like perforation and bowel obstruction, lymphovascular invasion, poor differentiation status, a number of other factors that contribute varying amounts of prognostic information and that help guide the decision. Is my patient sitting in front of me high enough risk of recurrence to potentially warrant the use of adjuvant chemotherapy in this setting? And so when we look at when a patient comes in, they're obviously not treated with adjuvant chemotherapy yet, and you're trying to make the decision of what to do for them. They've had surgery, and now they're post-surgical patients. So looking at the risk factors that we have, the patients that don't have low risk, don't have risk factors that would necessarily identify them, these patients typically don't receive adjuvant chemotherapy in the stage 2 setting, whereas patients with those high risk factors that I mentioned are the ones that are considered for adjuvant chemotherapy. But what you see here, when those high-risk patients are separated by Immunoscore, the dark blue line being highly infiltrated Immunoscore high patient tumors, those patients have a nearly identical survival profile as patients that are low clinical risk and would not receive adjuvant chemotherapy. And this actually turns out to be a large proportion of those high-risk patients. 7 out of 10 patients that have an Immunoscore high classification profile are associated with a good clinical outcome and might be spared the side effects of adjuvant chemotherapy in this setting. I'm going to skip that slide. Now we're talking, in the title of this presentation, one of the novel pieces of data that have come out of this Society for Immunotherapy of Cancer Consensus Immunoscore program were the subset analysis of the T4N0 patients. These patients are one of the highest risk in terms of the risk assessment classification, and really this is a population with T4 tumor status that really is considered seriously for adjuvant chemotherapy decisions. So many of these patients end up getting treated. In the subset of T4N0 patients in the SITC study, this was just published or just presented at ASCO this year, just a month ago. These untreated patients, 132 patients were untreated in this analysis, despite having T4 tumor size. And the Immunoscore could identify very significantly two different survival profiles, where patients with Immunoscore high, so highly infiltrated tumors, had really good outcomes. This is not what one would expect for a T4 patient, and these outcomes are similar. Again, thinking back to a couple slides before, the patients who have clinical pathologic low risk tumors. So we're talking about a 12% recurrence rate at 5 years, compared to Immunoscore low patients who have almost a 59% recurrence rate at 5 years. So really, you can differentiate using the Immunoscore the patients who are at low risk compared to the patients who are really at a high risk. And in this case, 2/3 of patients were identified as having this biological low risk profile, and these patients might be spared adjuvant chemotherapy. So Jérôme will talk a little bit more about TNMI in the next part of the presentation, but I wanted to go over how Immunoscore is being incorporated into clinical decisions for these stage 2 colon cancer patients. So if you look on the left side, patients are typically assessed via standard clinical pathologic factors into two groups, the low risk and the high risk tumors. For those high risk patients, they're often considered candidates for adjuvant chemotherapy. However, large majority, 70–80% of these patients actually have a high degree of immune cell infiltration at the site of the tumor, and thus can be reclassified as low risk patients, in which they might be considered only for surgical management, which would be a practice-changing type of scenario for these high-risk patients. On the other side of the clinical risk coin, the low-risk patients, there are those low-risk patients that do have a high risk of biological recurrence, as identified by the Immunoscore, a low degree of immune cell infiltration, and these patients might be followed more closely and considered as a high-risk patient. So thinking about this in a biological paradigm and the incorporation of the immune response into clinical decision-making can have a real impact for patients and society in general. So I'll really quickly talk about a case study here. This is not an individual patient, but this is representative for the types of patients that are being considered. So you have a younger male patient with a high risk T4A colonic adenocarcinoma, poorly differentiated tumor, and microsatellite stable. This would typically be a patient, this T4, that provided there are no other comorbidities that would prevent the application of or the prescription of adjuvant chemotherapy. This might be a patient that would be considered. In the case where the tumor 2/3 of the time, and as shown by the validation of the SITC data, showed that Immunoscore was high for this type of patient, they have a really much better prognosis than one would expect. 12% recurrence rate over 5 years. This might be a setting where a patient would be considered to not be prescribed adjuvant chemotherapy. This is particularly important in the background of the epidemic that we're all experiencing, especially in the healthcare space, where just bringing a patient into the hospital, treating them with an immunosuppressive chemotherapy is really something that you want to be sure about, because the risk of, if they become infected with COVID, or with SARS-CoV-2, the morbidity we think at this point is much higher in these patients who are undergoing adjuvant chemotherapy, and especially with the consideration might be to stop that therapy, which in this intention is supposed to be curative. So you want to make sure that you actually are treating the right patients, and the Immunoscore can help to do that. As I've shown in some of the previous slides, a lot of these patients actually are at a very low risk of recurrence, and incorporating Immunoscore into the clinical decision making for these high-risk patients can reduce the application of adjuvant chemotherapy to those who really are the highest risk patients, and thus preventing nosocomial infection associated with the hospital and the application of adjuvant chemotherapy. So I think this is, we'll skip the stage 3 data for now, but there's been a lot of published literature, especially this last year, talking about stage 3 patients, the use of Immunoscore to help guide therapy in some of those patients in terms of the duration. And thank you very much again for joining us. I'll turn it over to Jérôme.
Thank you, Graham. Thank you. And I will move to the second part of the talk. Can you hear me well? Are the slides okay? If so,
good.
If so, I will move to the second part, the TNM-I, TNM-Immune classification staging system. And this is based on this multi-center international SITC study analyzing the consensus Immunoscore. And the reason we wanted to move to a TNM-I, TNM-Immune, and we actually proposed together with all the pathologists and oncologists from the consortium in this review article in the Journal of Pathology in 2014, towards the introduction of the Immunoscore into the classification of malignant tumors. The reason is because today, when a patient is coming at the hospital, the clinicians and nobody knows anything about the patient, about the immunity of the patient, about the immune system of the patient, about the immune response to cancer. Because all the parameters that are measured in routine clinical practice are all about the tumor cells characteristics. Of course, the extension, the invasion, the TNM staging system, plus multiple ways to characterize the tumor cells or tumor features with anatomopathology, lymphatic invasion, perineural invasion, the grade of differentiation of the tumor, etc., plus multiple molecular features of the tumor. But there is not a single test except the Immunoscore that can be done in routine practice that will tell you something about your patient, about the immunity of the patient. And so we published this international validation of the consensus Immunoscore for the classification of colon cancer in Lancet with all those 100 co-authors. And following that publication, I recently presented at ESMO-GI, so a few days ago actually, this proposal for including a first immune parameter, Immunoscore, into the classification of colon cancer. So moving from the TNM 8th edition to the TNM-I. So the study that was done is based on this cohort of 2,650 patients. The median age is 67 years old with this ratio 51.5% male. The number of lymph nodes at all the stages evaluated is 18.9 lymph nodes. In the stage 2 patients, the mean number of lymph nodes evaluated in the study is 20.1. And you can see here the proportion of patients based on the TNM 8th edition, so T1, T2, T3, T4A, and T4B, the proportion of patients as well as the proportion with the end stage, and the proportion of patients according to Immunoscore, stratifying the patients with the 5 categories of Immunoscore: Immunoscore 0, the lowest Immunoscore, Immunoscore 1, 2, 3, and 4, 4 being the highest Immunoscore. And basically, if now you look at the current TNM 8th edition, you can see that the patients are staged according to the TNM staging system based on these T stage categories, N stage categories, and M stage categories. Now, if we look at the evolution of this TNM staging system from the 5th edition, that was in 1997, this was how it was, patients were staged, to the TNM-6 in 2002, TNM-7 in 2009, TNM-8 in 2016. And now you can see so the evolution and the changes in the categories of the patients. And now you can see the changes that will occur if you now have the immune evaluation of the patients. This is introducing for the first time an immune parameter into this TNM classification. And if you do that, then you will see that in fact you have patients that have in fact a very high risk based on Immunoscore, but these patients were considered low risk with the classical tumor parameters and vice versa. There are some patients that you would consider high risk with pathological tumor parameters that are in fact low risk now if you consider the immunity of the patient. And so now you see the changes in terms of proportion of the patients that are changing categories. Now, if you take into consideration this immunity, this Immunoscore of the patient. So how does it perform to have this novel TNM-I classification? So now you introduce the patients, and on this chart now you can see the patients that are either changing for a better class category, so a better tier, so basically having a better outcome compared to the previous classification, or have a similar outcome, so meaning they are not changing categories, or that have a worse outcome, meaning that the Immunoscore would tell you that the patient is in fact at a higher risk. So you have all the, on the x-axis, the stages from the TNM 8th edition. And now you can see at each of those stages, what is the proportion of patients that are changing to better in pink or worse outcome in blue. You can see that some patients, even in stage 1, are changing for better or changing for worse. And then you can see stage 2A, stage 2B. In fact, all patients in stage 2B are changing categories either for a better or for a worse category. Likewise in stage 2C, 3A, and I plotted for 3B just for you to see an example of the hazard ratio. You know, if you put all the patients that are changing categories for better, you can see an hazard ratio of 0.59 with a p-value of 0.00001. So a much better outcome, better than expected with the TNM-8, the 3B, if you now add the Immunoscore. And you can see the patients that are getting worse than 3B with an hazard ratio of 1.7 and also very significant p-value. So you can now have a different view of your patient if you integrate the immunity of the patient. And this is now the comparison of the TNM 8th edition versus this TNM-I classification. You can see the hazard ratio compared to the best category, stage 1 patients. So you can see that with the TNM-8, you have some discrepancies between stages, meaning that you have patients that have in fact a better outcome even though they have a worse category. Like for example, the 3A would have a much better outcome than the 2C or even the 2B. And you can see that the 3B will also have a worse, a better outcome than patients with stage 2. So in fact, the TNM-8 is far from perfect. Now, if you move to the TNM-I, you can see the TNM-I categories from 1A, categories TNM-I 1A to 3C, the constant increase in the hazard ratio. You can see the real values of the multivariate hazard ratio, moving from 2.5 hazard ratio to 3.3, 4, 4.5, 5.7, 9.5, 10, and up to 12.3 hazard ratio, all p-value being extremely significant. So you have a much better way to stratify these patients. In addition, now if you look at the prognosis of those patients, and this is a 10 years, 120 months, 10 years follow-up on those patients, classify now with this novel TNM-Immune classification, you can see the outcome of the patients depending on the TNM-Immune from 1A on the top, the purple curves here, very good outcome, disease-free survival here, down to the 3C. More importantly, now if we plot multivariate analysis, this is the relative contribution to the risk, comparing this novel TNM-I, TNM-Immune classification with the current TNM 8th edition, TNM-8, you can see that the TNM-I is way superior to the TNM-8 and in fact contributes to more than 95% of the risk. And in the multivariate, if you now look at the significance between all the stages from TNM-8 versus all the stages from TNM-I, all the TNM-I stages are significant and none of the TNM-8 stages are significant. So basically, these survival curves shows a major stratification and a better stratification of the patients with the TNM-I, and we have similar results for DFS, time to recurrence, or overall survival. So importantly, the last point is when you want to introduce a novel classification, you have to compare it to the previous classification. So this is the statistical test, the delta AIC, to measure the improvement from one classification to the next. And basically, it shows for time to recurrence, disease-free survival, or overall survival, that between the TNM editions, there was a major improvement from TNM-5 to TNM-6 that you can see on this graph. But from TNM-6 to 7 and to TNM-8, in fact, there was no major improvement, if any, in terms of stratifying cancer patients. But now with the TNM-I, you can see this major improvement of the classification, both for time to recurrence, disease-free survival, and overall survival. So how does it translate? If we take an example, we were talking about the T4N0 patients. With the current staging system, the TNM-8, you have either T4A or T4B, and those patients would be classified as 2B or 2C and would be considered high risk. As now, if you introduce Immunoscore, now you have the patients that will move from a stage 2 high risk to a stage 1B, 2A, or 3A, meaning that the patients would have either a much better outcome compared to the existing classification or a worse outcome, which was shown on the survival curves by Graham. And if you translate that now into clinical decision making, now you have the patients that are either T4A, stage 2B, or T4B, stage 2C. And if you stratify those patients with Immunoscore now, you will have, in fact, 66%, two-thirds of those patients being Immunoscore high in both categories of T4A and T4B. And those patients with a high Immunoscore, in fact, have a low risk of relapse, in fact, are similar to low-risk patients, and in fact, could be spared from adjuvant chemotherapy. And you have the low Immunoscore patients within the T4 population that are even worse than the regular T4, that are really, really high risk. And those patients, you, of course, could consider them for adjuvant chemotherapy. Finally, as it was mentioned by Graham, the latest edition of the WHO book for the classification of digestive system tumors introduced for the first time the immune response into the book as an essential and desirable diagnostic criteria for colorectal cancer, in addition to the TNM grade of the tumors. And the immune response was described as being a standardized examination of the presence of lymphocytes at the invasive front of the tumor using immunohistochemistry for CD3 and CD8, showing that this feature has a prognostic power, and citing our Lancet Immunoscore consensus article. So since now it is introduced into the WHO, we think that the next phase will be the introduction into the AGCC UICC TNM staging system to move from the regular TNM to a TNM-I, TNM-Immune classification. And with that, I'd like to conclude that there is a clinical value that is demonstrated in many published studies and ongoing studies. The use in clinical routine to improve colon cancer patient management can be done today. Immunoscore is available in Europe, in Asia, in the US, and everywhere, and it helps refining the current classification, moving to a TNM-Immune classification, and taking for the first time into consideration the patient, the immunity of the patient. And with that, I'd like to thank you for your attention, and we are now moving to the Q&A session.
Thank you, Dr. Galon, and thank you, Dr. Poage, for your informative presentations. We will now start the live Q&A portion of our webinar. Now, to our audience, if you have any questions you would like to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we will answer as many of your questions as we have time for. Okay, let's get started. Let's start with our first question here. Dr. Graham, let's ask this question to you. How can I access Immunoscore for my practice?
Hi, thank you. Yes, so we get the question a lot of, these data look really interesting. How do I integrate this into our system? We have a network in the U.S. of account representatives that you can send us an email. You can go to our website, get in contact with us. You see the contact for additional questions, as well as information about ordering. There across the world, there are a number of distributors, as well as some direct account representatives. The website and the email here are your central point in case you would like to activate this in your practice. Just send us an email. There actually, you can even request a TRF on our website to get access to Immunoscore for your patients.
Thank you, Dr. Poage. And Dr. Galon, let's come over to you for this question. Why should I include immune response in the TNM over other parameters?
Yeah, thank you for this question. So I think the data speaks for themselves. I mean, when you want to integrate a novel parameter, you have to make sure that this parameter is informative, is not redundant with other parameters. And for that, there are multiple statistical tests. Of course, one of the main tests is the multivariate statistical analysis to test the strength and the dependency of the parameters. And in fact, when you look at all the parameters, existing parameters that are done in routine clinical practice, so TNM, MSI testing, grade of differentiation, venous emboly, lymphatic invasion, mucinous, all the parameters that you can think of, and you add now Immunoscore to these parameters. Immunoscore on the multivariate analysis is the strongest parameters and is, of course, significant in multivariate analysis, and in addition to that, it takes over most of the power of the other parameters. And in addition, if now you look at the relative contribution to the risk and you compare the risk of attributed to each parameter, you can see that Immunoscore represents half of the risk considering all stages, and represent even more than half of the risk comparing, analyzing subsets of patients in stage 2 or in stage 3. So in fact, it is the strongest parameter ever seen and is superior to the existing TNM staging system. So this is why we think that now this novel view on cancer, meaning that the immunity of the patient is far informative and is very informative, now is a strong argument for its introduction into classification.
Thank you, Dr. Galon. And let's have you answer this question as well. Why should I incorporate an IS result in the decision-making process when we know that T4 is a high-risk factor?
Sure, yeah. Actually, can I go back to one of the slides to how the audience seeing the slides still?
Yes.
Because I think the slide speaks for itself. I mean, of course, T4 is a high-risk factor. But now, not all patients with a T4 will have the same outcome. And in fact, they are not all of them high risk. Some of them, stage 2 T4 patients, will not have tumor recurrence, and some will have tumor recurrence. So how does it stratify patients with T4? Now, if you add Immunoscore, and if you look at the Immunoscore of the patients, and this is the results, basically, showing in that very precise population of T4 patients, how does it look when the patient is Immunoscore high? It looks very good for the patient. In fact, the patient have a very good outcome for a very long time, as you can see here, with only 12% of relapse on that population. And in fact, the real high risk are not all the T4 patients, but only the T4 who have a low Immunoscore, the pink curves. So you see the huge difference depending on the Immunoscore in that very homogeneous population of patients being all T4. So not all T4 are high risk. Only the T4 with a low Immunoscore are of high risk.
Thank you. Now, Dr. Pogue, let's come over to you for this next question. How can I reassure my patient about the de-escalation strategy?
Yeah, that's a good question. Can everybody go on mute? Awesome. So I think Jérôme mostly just answered that question. Actually, is it's important to go back to the data and understand what is the risk of recurrence associated with the immunoscores. If we're talking about the stage 2 patient and they have a tumor that's associated with a high clinical risk but an immunoscore high, we're talking about a 13% risk of recurrence. And in the conversation that might take place, you absolutely have to start with the data and have your patient understand what is their risk of recurrence, because that is important to them. What do they do? What do physicians typically recommend for these type of patients who have about a 10% 5-year risk of recurrence? For these low-risk patients, that typically they don't get considered for adjuvant chemotherapy. So if you can identify a biological-based risk of recurrence that puts them in a bucket that reclassifies them as low risk, that's very powerful for understanding, having the patient understand what their tumor is doing, how it's interacting with the immune system, and how the immune system is restricting it from advancement.
Thank you, Dr. Pogue. And Dr. Galon, let's come over to you for this next question. What momentum do you have for the AJCC staging manual editors to incorporate the TNM-I in the next edition, the 9th edition?
So thank you for the question. So two things. So we have generated and published multiple articles, in particular in 2020, this year, about the importance of Immunoscore, so about both the quality and robustness of the test first. Second, about the major stratification power Immunoscore has at all the stages, so all stage 1, 2, 3. We have also 3 publications on stage 4. We have now 2 additional randomized phase 3 clinical trials in stage 3 patients showing both the prognostic value of Immunoscore and, in addition, the predictive value of Immunoscore in response to chemotherapy. And of course, we have all the data on early stage 2, including the T4 patients, subpopulations, including this upcoming article about the TNM-I comparison to the TNM-8. And in addition, we have now this introduction into the WHO book, the WHO classification, this immune response criteria evaluated by Immunoscore that has been introduced for the first time into the WHO book. So all these clinical utility and inclusion already in some guidelines gives a path for introducing Immunoscore and the immune response into the TNM staging system and to the AGCC. However, I have to say that I don't know anybody on those AGCC committees, and if anyone knows and could support, I mean, we would be more than happy to discuss.
Thank you, Dr. Galon. I'm going to have you answer this next question. We just have a little feedback, so let's get you muted so I can ask it. Okay. Are results from any NGS tumor testing, WES or RNA-seq, etc., included in the scoring, or is it strictly based on T-cell IHC staining?
Yeah, it's only based on immunohistochemistry staining with 2 markers, staining for overall T cells and cytotoxic T cells, and it's based on digital pathology, allowing to count every single T cell on the tissue. So basically, when you have a routine slide from a pathology department, then all the T cells that are present on that tumor on that slide are counted. And I can tell you that the mean number of T cells counted by the software is 88,000 T cells. So there's a huge number of T cells and a huge number of T cells that are counted. And it's purely based on visual and immunohistochemistry-based quantification of immune cell infiltration within tissue, taking into consideration also the spatial information, meaning the tumor and the invasive margin of the tumor. And there's no NGS testing required or anything like this.
Thank you. And I'm actually going to have you answer one more question here. Are there clinical pathological characteristics, such as MSI status, that overlap with Immunoscore high condition? And is there any value in traditional stage 2 risk factors?
So so we published several articles, including one in 2016 in Immunity, in which we deeply analyzed the relationship between the MSI status and the Immunoscore. So basically, what we found, and others have found, and we found that in several cohorts and in several publications now, is that more frequently, MSI patients would have a high Immunoscore. However, there could be MSI high patients that have a low immunoscore. And in that case, they don't have a good outcome. And vice versa, there are some MSS stable patients that have a high immunoscore, as high as MSI patients, and those patients are doing extremely well. And in fact, so there's a mechanistic relationship between the DNA mismatch repair deficiency and the immunogenic epitopes and the T cells. However, what's more important? Well, to define what's more important, you do a multivariate analysis, and you put in the multivariate analysis MSI and immunoscore. And what's left in all the publications we have in the Lancet, in the Immunity, in all cohorts analyzed, when you have MSI and immunoscore together on the multivariate analysis, only immunoscore remains significant, and the MSI status is no longer significant, meaning that the strength of immunoscore is superior to the MSI value, and meaning that there is a dependency between MSI and immunoscore. Now, talking about value in the traditional stage 2 risk factors, well, this is seen on that slide that is currently here on the screen. These are the stage 2 patients with the traditional risk factors for stage 2. So these are high risk factors. So venous emboli, lymphatic invasion, being a T4 tumor, etc. And in fact, what you see here is that, again, only the low immunoscore patients have a high risk among those patients. And those who have a high immunoscore are in fact similar to low-risk patients. The two blue curves, the dotted line are the low-risk patients, and the plain blue line are the high-risk patients based on pathological parameters, but they have a high immunoscore, a good immunity. And you see that these two groups of patients are very similar, and in fact the real high risk are only the ones, the pink ones, that have a low immunoscore. I think that.
Okay, and thank you. Another question, is there any correlation between immunoscore and circulating biomarkers such as CTDNA? And Dr. Galon, you can answer this one as well.
So we don't have yet a formal analysis to measure the correlation between immunoscore and circulating CTDNA. So what I can say is that, of course, immunoscore is, among all the parameters that we mentioned, including T stage, including N stage, is stronger in terms of stratifying patients at all those biomarkers. We will have to see in the randomized trials in which CTDNA has been performed how it correlates. It could be very complementary, in fact, to have both information. The immunoscore at diagnosis, which really tells you is your patient high risk or low risk, and then to have as an additional analysis the ctDNA performed as a follow-up analysis to see whether the patient is relapsing. And so these two tests could be very, very complementary for that reason.
Thank you, Dr. Galon. And we've had so many excellent questions coming in, but I'm sorry to say we have run out of time. But I do want our audience to know that those questions that were submitted today that we were unable to answer, and additionally those questions that are submitted during the on-demand period, they will be answered by our speakers via the email address that you provided at your time of registration. Now, I do want to give Dr. Poage and Dr. Galon an opportunity for any final comments for our audience.
Thank you very much for joining. It was really patient. Thank you for the questions, and everyone stay safe.
Yeah, thank you all for being here and for listening. We will surely answer all of your questions, and thank you for your attention.
Dr. Poage, Dr. Galon, thank you so much for your time today and your important research. We would also like to thank Labroots and our sponsor, HalioDx, for underwriting today's educational webcast. Today's webcast can be viewed on demand, and Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. That's all for now. We hope to see you again soon. Have a great day.